Good afternoon, everyone. This is a webcast sponsored by HeartLung.AI in collaboration with SCCT, and I'm pleased to have a distinguished panel comprising leading cardiovascular and lung cancer screening researchers and practitioners who are early adopters in the field. So with that introduction of the title and the focus, which is on this screen, we will be sharing with you the work that we have done in the past few years in collaboration with our co-investigators under AI-CVD consortium from various academic institutions that brought us to this point where we are ready to share the introduction of the next generation of calcium scoring in the era of AI, in particular here, AI-CAC and AI-CVD. We are delighted that Dr. Arthur Agatston, whose name is on the calcium scoring technique, is part of our panel, and he's been, in fact, an active participant in our research meetings and contributed to development of this new presentation. Without further ado, I'd like to invite panel members to please unmute and introduce themselves. On the right side on my screen is Dr. Claudia Henschke, and then we go down with Dr. Agatston. Claudia?
Yes, I'm a professor of radiology. First of all, wonderful to be here. And I'm a professor of radiology and started lung cancer screening together with my colleague, David Yankelevitz. And we were very interested in reporting ordinal scores from as soon as we could on every low-dose CT scan of the lungs.
Thank you. Arthur?
Arthur Agatston, practicing cardiologist, professor of medicine at Florida International University, and been very active and interested in this, and good to see old friends and new friends. The early work we did a lot with John Rumberger and Nathan Wong. We called it the Calcium Club, and Mort joined a little bit later.
Yes, I'm a late arriver. Thank you, Arthur. We're going down. Tony?
Good day. My name's Tony Reeves. I'm a professor in electrical computer engineering at Cornell University, and I've been working on image analysis methods, both for lung and heart, for many years, and I look forward to seeing how this particular venture plays out. It's very exciting to be involved.
Thank you, Tony. Next, Nathan.
Hi, everyone. I'm Nathan Wong. I'm a cardiovascular epidemiologist and professor and director of the Heart Disease Prevention Program at the Mary and Steve Wen Cardiovascular Division of University of California, Irvine. And I've been very involved, like several of the rest of you, and have enjoyed doing some of the pioneer work in coronary calcium along with Dr. Agatston and Dr. Rumberger and others over the decades. And I'm very excited to see these new developments with AI-CVD and how it can really take us to the next level in preventive cardiology.
Thanks, Nathan. John?
Yeah, hi, this is John Osborne from Dallas, Texas, the founder of Clear Cardio, a preventative cardiology program, which leverages now for 25 years cardiac CT for early diagnosis of cardiovascular disease, and really excited to see how cardiovascular CT has evolved to be a multimodality tool of detection.
Thank you, John. The other John Rumberger.
Hello, I'm John Rumberger. I've been a fan of this for many years. Arthur Agatston and I sort of started together this back in the Calcium Club days, and I was responsible for doing a lot of the pathologic validation work for coronary artery calcification. I continue to be that. I'm a former professor at the Mayo Clinic, and now I'm a director of Corazon Imaging, medical director and chief science officer along the way. And I'm excited to see all of this development, especially as I have personally also gotten into the artificial intelligence situation. And this is just very, very exciting. Thank you.
Thank you, John. Tom?
Hi, I'm Tom Atlas, private practice radiologist based in Tustin, California. My specialty is body imaging, but I also do a significant number of the lung cancer screening and the coronary artery calcium type scans. So it's just is part of the general practice I'm in.
Thanks, Tom. David?
Hi, David Yankelevitz. I'm a radiologist over at Mount Sinai Hospital here in New York City. Along with Claudia, we actually started low-dose CT screening for lung cancer back in 1992. I am not a member of the Calcium Club, and however, I followed their work very closely, and Claudia and I became so interested in it that we introduced it into low-dose CT screening, where we developed an ordinal score and have been continuing to work on calcium scoring introduced into lung cancer screening since then, and seen all the amazing progress that's been made.
Thanks, David. We're happy that you and Claudia and Tom from the non-cardiology world are part of this. And this is going to be an exciting venture. This is just the beginning, and we hope that this collaboration between multidisciplinary diseases, lung cancer screening, emphysema, COPD, cardiovascular disease, and cardiometabolic and kidney will bring AI will bring all of them together under the umbrella of a chest CT. And that's the project that we're developing towards, and we'll be having a separate symposium at American Heart Association's conference in New Orleans in a few weeks. Without further ado, I'd like to invite our chief engineer, Dr. Anthony Reeves, who, as he said, professor at Cornell University, to walk us through the technical aspects of what Agatston 2.0 AI-CAC is, how it is different than the legacy Agatston score, and how it moves the field forward by addressing the issues that were identified in the original scoring technique. Then I will add additional lights on each of the components of AI-CVD. As you can see on this screen, AI-CAC and coronary calcification is one component, but perhaps the most important component. And then we engage our panel to talk about various cases that they have experienced and summarize our findings with regard to AI-CVD as the umbrella and Agatston 2.0 scoring technique and how to bring it to practice. Tony?
Yes, I'm honored to be presenting about this scoring system that has been one of the few radiological scoring systems I'm aware of that has been so widely accepted. And the goal here is to estimate the risk of calcium deposits in the coronary artery system with respect to heart disease. And I just very quickly go through the algorithm. I'm sure everyone is in the audience is aware of that. The first step is that we're on the right here, you could see several examples of different levels of the scoring system. The top left image there shows no calcium. The top right shows a single deposit of calcium in one of the coronary arteries, and that would be like a mild score as rated by 29. And then we see the two lower images with more increasing levels of calcium. The way that this algorithm works is someone with experience that can identify these calcium plaques and not get them confused with other calcium deposits that are in associated anatomy very close to, just get the ones in the coronary arteries through all the different images in this CT scan and circle them with some device and indicate that they're the ones to be scored. Then there is some minimal software that goes through, takes those areas, and then we get to the algorithm on the left for each of the areas that that person scores. And this is quite laborious. It's not much of a problem with the top two images, but if you get the bottom right image and you have to circle everything there, which is actually in the coronary arteries, it can be a little bit labor intensive. So for each of those circled regions, it is thresholded at 130 Hounsfield units, and it's made sure that each deposit is at least 1 millimeter squared, which means about 4 pixels in the typical image that this was defined for. And then in that region, we count the number of voxels that are greater than 130 and take the highest value voxel in there in step 2. And then if it's very high, we amplify its importance by that weighting scheme there. So if it's greater than 199 Hounsfield units, then it gets double the weight, and so on and so forth, up to 4 different levels there. And finally, once you have scored every one of these regions, you then sum up a total score, which is simply add them all up, and that is your CAC score. The only point I'd make that this was done in the technology of the E-beam CT scanners, which were super fast at the time, and they had a restriction of only 3 millimeter slice thickness scans. So that put one of the constraints on that remained for many years. Now all scanners have thinner slice capability, but everybody uses this still as the reference. Next slide. So I just wanted, as I'm introducing technology here, to give a bit of a context that the Agatston score was defined in 1990, which was 35 years ago, and it is still the standard today. What's changed in technology? And the answer is a lot. In CT technology, we have thin slices, iterative reconstruction, a whole bunch of new things. I'm going to cover those later. I just wanted to just touch bases on what was going on at that time. And it turns out 1990, as an example, was the first year that digital cameras came out for general use. It was the first time you could see a photograph you'd taken and before the film had to be taken and developed. So that was a great move forward in imaging. At the same year. And then 9 years later, the first cellular phone incorporated the first carrier at about 0.1 megapixels resolution. 6 years later, the iPhones came out with 2 megapixel cameras, and now the current iPhone has a 48 megapixel camera. And when you take a photograph, instead of turning all those dials, the AI inside the iPhone makes all those fancy adjustments and does an absolute brilliant job of taking that photograph for you. So that's how much that technology has changed in the 35 years that the Agatston score has not been updated. Put that in context now with AI, which is what we're using throughout the new version. And at the time that the score came up, if you had a large workstation, it might have a teraflop of power. Now, that's vastly more than you need for the Agatston score, But that was kind of the level of computational power typical of the time. In 2017, 8 years ago, NVIDIA decided we could benefit from an AI-directed GPU addition, which is in most computers today. And that boosted performance from that 1 teraflop, which is 1,000 million operations per second, by a factor of 125, one step. And now, a few years later, that, of course, we're at about 4 or 5 times that performance. And if and that with that kind of device in your small computer, you generate a little bit of heat to keep the room warm as well. But if you really want compute power, you go to a data center where with just 72 of those devices in a rack, you can be getting 1 million times more performance. And it's very hard to imagine exactly what that is, but beyond the fact that it also contributes to global warming. Final point, though, for Agatston 2.0, what I'm about to introduce, it doesn't need the super levels of power that are currently available. It can run on a laptop, which of course would have an AI GPU in it. Next slide. So here's then the basic overview of the algorithm itself. We're comparing on the left, developed by Arthur Agatston and his colleagues for 3mm EBCT 35 years ago. There's the opening of their initial paper. And on the right, I'm going to be covering the AI-enabled AI-CAC score for all CT scans of the heart, basically, not just those with the EBCT or not just those with 3mm. Next. The application, as I indicated, there was some manual skill required to identify the regions of interest. In recent years, there has been some updates, so in that regard, so there are now systems out there that can do this fairly automatically. On the new side, it's totally fully automated, and now the AI isn't just doing the score, but it's assisting in a lot of those things. And it started off by saying, not just the calcium, let's do all of the coronary arteries, the main coronary arteries from which the score is obtained. Next. Calibration has no calibration that was explicitly required in Agatston 1.0. But we know we're doing, and that algorithm did thresholds, so it was going to be highly dependent on how well the CT scanner was calibrated. So in Agatston 2.0, we use, if it's available, a phantom. And if we don't have a phantom, we use a surrogate for that, which in our case is subcutaneous fat. And that is calibrating not just for intensity, but also compensating for the different levels of noise that we acquire in CT scans. Next. The algorithm itself. In the original, it is something one can simply do and be sure that you get it right with an absolute minimal computer if you needs to calculate the maximum value is very simple spreadsheet type calculation. In our modified, we avoid using a strict threshold and increments at different levels. We just say, no, we're not going to even chop out what is considered to be the calcium. We're going to look at the whole coronary artery. We're going to do nonlinear weighting of the pixel values, and we're going to do some neighborhood operating that corresponds to saying several pixels are needed to confirm that it's a calcium entity and not just image noise. So we have the same ingredients, but we're now doing this in a generic concept test context, taking into consideration linear functions or nonlinear functions rather than the thresholds used in the original method. Next. And finally, the original scoring system provided a single CAC score as a quantifier of risk. And as we'll see today, that would be our primary output, but we can also calculate other parameters as well that may give a more detailed picture of the of heart health. So with that, I'll pass on to the techniques here. The first thing is for calibration. We need to know for that scanner the calibration and intensity and the quantity of noise in the scan. And if we have a phantom, then we automatically select that region and measure the phantom characteristics. If we don't have a phantom at, say, around 100 Hainsville units, then we use subcutaneous fat, which is fairly well standardized at about 90 Hounsfield units, we found. And we do transform that into the range that we're interested with and calibrate it again in a similar way we do for the phantom. And that is all done automatically by AI. The AI then comes into this step that now we can, without manual help at all, identify the main coronary arteries, and we segment them out from, and that's the region that we actually explore. On the left, you can see the main arteries with the aorta put in there for reference. And on the right, you can see them, and they have been labeled with respect to their main names, so that if we wish, we can do individual artery analysis to do a more refined sort of evaluation of the health. So here now is how we formulate the score. On the top right, you see we start with the whole coronary artery region. We then process the pixels through an intensity transform that is calibrated by noise and intensity calibration from our phantom readings. We then go to step 3, a neighbor filtering process that gives us more noise robustness. And then finally, as with the original count, we score over all our scored readings, just sum them up. But again, in this case, we're doing it over the arteries, the whole arteries. We're not just identifying the high calcified regions when we do that summation. Next. So there has been a lot of work focused on could we not modify Agatston 1.0, and it's turned out that this is a very challenging process. If we were to suggest, say, well, it's not quite sensitive enough. How about we use 120 instead of 130? The type of study that would be involved to try and prove that would be very hard to accomplish, and it has not been accomplished. So today, 35 years later, we have not modified that, although a lot of people have done studies suggesting that modifications might give an improved score. Here's one paper that does a very good review of things that could be done to improve the standard Agatston 1.0 method. And this is by Williman in 2017. And for then at that time, first go to thin slice reconstructions. Second, iterative reconstructions are going to give you less noise and better discernible quality. Third, now with the new scanners, you can go to a lower KVP and you can get more information about the soft plaque. And click, would you more? Yep. And now, of course, that was too early to say, but now we're in 2021. We have photon counting technology, which today is expensive, but in years to come, I would say is pretty confidently going to just simply replace the scintillation method that we currently have in use today. So more things are coming and evolving. On the right, you can see, no, go back one, please. Thank you. The figure showing the impact of different slice thickness. We're doing 1 millimeter by 1 millimeter in X and Y, but in Z, because of those initial CT scanners, we're doing 3 millimeter steps. And you can see on the left image that there are calcifications in that figure. Small calcifications only take a part of the 3 millimeter region. Larger calcifications still don't necessarily cover 3 millimeters. And if you look on the right side, you would see if you took thin slices, then the small calcification, which on the left has essentially disappeared through averaging, is quite clear, and that even makes an appearance on the right side. So there's the obvious move to go to thinner slices there. And next slide. And this is the next image from the paper showing on the left a 3 millimeter reconstruction, on the right a 0.6 millimeter reconstruction. And it's as obvious on the right-hand image that we do have a calcification, and on the left it is below the 130, and it is too low to be scored in almost any method. So this is very well understood, and I think with our 2.0 approach, we are at last getting to address some of these. So in summary, the 2.0 AI-CAC score, Agatston, involves AI technology to identify coronary arteries automatically. So that manual step is out, and we're using the whole coronary arteries. It replaces the 130 Hounsfield cutoff with relative density units using a smoother function. It uses an AI segmented reference medium, phantoms or FAT, to adjust for noise and the calibration intensity, and it computes the relative density of all voxels of the entire coronary tree. It doesn't just focus on the highly intense calcifications. And that produces an Agatston 2.0 CAC plaque burden score that has comparable to the original Agatston score. In addition, we can now compute additional scores like the hypodensity voxels, and reports Agatston 2.0 plaque density score, as well as an overall calcium burden score. So with that,
You're on mute, Dr. Nagavi.
Sorry. Thanks, Tony. So that was a good summary of 35 years of cardiology being where Arthur Agatston and John Rumberger and Bob DeTrano started. And now we've inherited about 35 years of research and evidence. So what I'm showing is not something that I developed over the past few years, my team developed. This is sitting on the back of all those researchers who worked tirelessly over the years, including the Calcium Club, who fought to get their voice out and were not appreciated at the time. I think we are at the stage that the evidence is indisputable, and I'm just going to walk you through the clinical values or value propositions that Agatston 2.0 brings over Agatston 1.0. So we're breaking into two groups. The one advancement comes because now, as Tony said, we don't have a fixed 130 Hounsfield unit. We can go down all the way to 90 and then adjust for noise. So we have a good infrastructure to identify small plaques, semi-calcified plaques, soft plaques, whatever you call it, that were previously ignored or missed. And so we have data to show you that once we do that, we identify people who have CAC 0 and had events that were actually not CAC 0. And I'll show you the data. Then on the right side, we address the other problem that Agatston 1.0 had. So one problem is some people have events, their CAC is 0, they're usually younger than 55. And then the other problem is when we treat patients, both people who are treated and responding to treatment and those people who are not treated, both experience increased calcium score. So how do we distinguish that? Can we use CAC scoring or CAC scan for repeat scanning and monitoring response to therapy? And now with this AI-CAC Agatston 2.0, you'll see that the ratio of hyperdensity over hypodensity, because now we have relative density score, can tell you who's plaque being stabilized and actually reverses their risk. So in the CAC 0 population, let's put this one to bed first. At first, I'd like to emphasize the power of zero that Michael Blaha and Khurram Nasir and other colleagues established firmly that CAC 0 is very low risk. Even though you have a few examples and some of these presenters to start with a case example of a 50-year-old male had an event with a CAC 0, it was because that CAC 0 is because of the 3 millimeter in the original Agatston score. And now when you apply the AI-CAC, you improve on the very good power of zero that you already have. So in this case, I'm showing you multi-ethnic study of atherosclerosis cases. These are people who had events. So if you're wondering, over a period of 15 years, 80 people with CAC 0 had events, had coronary heart disease events. And this is heart events. Out of these 80, once we applied the AI-CAC, 68% of them were no longer zero. They were moved to AI-CAC greater than zero. And 25 stayed in AI-CAC. And if you focus on this range from 0 to 5, which is right here, which is what we recommend if we were to repeat calcium score in somebody who is CAC 0, you'll see we only have like 2 events. And we already know that a big chunk, maybe 5% or even more, of coronary events are not epicardial coronary related. They are microvascular coronary related. So I think with that incremental value that AI-CAC is offering, we're kind of reaching the ceiling in using CT scan to identify risk, coronary heart disease risk, based on anatomy of coronary. So I emphasize anatomy of coronary artery disease. There is not much room once you are able to detect almost everybody who had events. So that's one side of this. And that was MESA. This one is pooled MESA and Framingham Heart Study. And as you can see, it's very similar to what MESA showed us. That is, those people who had AI-CAC 0, which is green, versus those people who had AI-CAC greater than 0, have a significant difference in their risk. And the dotted blue or dashed blue in the middle is the original Agatston 1.0. This shows the same thing, that is correct at 5 years, 10 years, at 15 years. It also shows it's correct for heart events, all events, and MI. So it's consistent that AI-CAC improves on the power of zero across all categories of risk. Now we're coming to greater than CAC 0. So we addressed the problem that people refer to CAC 0, people have events, we identify them. Now we're talking about repeat CAC scans. Can we do repeat CAC scans and see who is improving or responding or who is building more plaque? And I'm going to invite Dr. Agatston to weigh in from his very long practice in this field, and he's shared with us a lot of cases that what he's referring to, these plaques age over time and become hypercalcified. And those who are getting treated, they get faster and more hypercalcification. So this graph, you see that over a period of 20 years, even adjusted by age on the right side, those who had hyperdensity or hypercalcification, their calcium is really high intensity, had less event rate compared to those who had lower density. If you put it in a 3D view, this is what you will see, that you have, around 0.3, which is 30% of hyperintensity voxels, you start seeing the risk going down. And the same thing here between AI-CAC and hyperdensity score on the left side. They show the same thing, two different angles. Here I'm going to just summarize that. In the first row in the bottom, AI-CAC 1 to 100. Remember, as Tony said, AI-CAC correlates with Agatston 1.0 in terms of the total burden. It just elaborates and provides incremental value. So 1 to 100 in ballpark is the same range as Agatston 1.0, and then 100 to 300 is intermediate and greater than 300. And I chose this because of the classifications that David Marin and Nathan Wong and Matt Budoff and others proposed for CAC-based staging. So as you can see, those people who have high CAC, greater than 300, if their hyperdensity, the ratio of hyperdensity over hypodensity, is greater than 25%, their risk significantly goes down compared to the highest group. And it's even more elaborate here. So the concept is, if you're able to use AI-CAC and report hypodensity over hyperdensity, we'll be able to evaluate response to therapy. Here is the therapy. Statin. In this group, this is MESA. On the left side, people were on a statin. On the right side, they were not on a statin. As you can see, those people who are on statin, if you follow their density, right around 30, 25, 30, 35, the risk reverses and it comes down to below the hazard ratio of 1. So that immediately conveys a protective value for increasing density, hyperdensity score. So Agatston score gives you the small soft plaque semi-calcified that are missed with the 2.0, were missed with 1.0, and then it gives you the density that changes over time, and you'll be able to monitor that. And as Tony said, we've tested it, AI-CAC, both with phantom and with fat. They have pretty good correlation, as you can see in this slide. So the summary here, I'm just going to encapsulate what Tony said and then move on to AI-CVD. And that is, we have moved the field forward by introducing Agatston 2.0 to further build on the 35 years of evidence that Agatston original scoring system introduced to preventive cardiology. AI-CAC can run, as Tony showed, on a thinner slice as well as on a thicker slice. In fact, all of these analyses that I've shown you from MESA were done AI-CAC on the 3 millimeter original old EBCT scans. So it shows the power of AI, that even though we don't have the high-end technologies like photon counting for our analysis, we're seeing the same value going forward. And this is moving further. We've not, Tony has not dived into it, but basically this is a real case, that's me. On the left side is a currently segmentation by AI-CAC from a non-contrast CAC scan. And on the right side, you'll see my CCTA report that I did at Harvard UCLA 2 years before. And so this is what we'll be building on. We'll be enhancing it, again, all to build on what has already been created. We're not revolutionizing or going a whole different direction. We're incrementally adding on the Agatston score that has been around. So now, this is the beautiful part of this, the just exciting part of this, and I credit David Yankelevitz in Claudia Henschke for opening my eyes to this value, because they were preaching it in their calcium club. It's called IO-CAP. And I tuned in and listened, and it's like, we should be able to bring AI and to make this available in a practical way for all. So that was 5 years ago when I met them. And now we're 5 years later at the FDA doorstep. Hopefully, when the government opens again, they will release this for patient care. That's our anticipation. So with that introduction, as you can see on this screen, we have several components. We won't have a lot of time to dive into each one of those in detail, but just know that we have published on all of these. We have close to 12 papers and 30 some abstracts submitted from a large group of people. Some of them, unfortunately, could not join here. I'm going to specifically credit David Marin from Stanford, Chief of Preventive Cardiology, and Mike McConnell, who've been very instrumental in helping us move this forward. So what are those components? As you can see at the top, we measure liver fat. A good chunk of liver is in the scan. We measure muscle density, muscle myosteatosis, which we have really exciting data to show you. And of course, body composition, visceral fat, pericardial fat, all of that. Then we report lung density, both on the low side, emphysema, and the high side, interstitial lung abnormalities. Then, of course, calcium score, we covered it. Thoracic aortic calcification and aortic valve calcification, both are part of the AI-CVD components. And then bone density, which was developed by Bob Detrano and his team, and then Matt Budoff significantly advanced it with tons of publication. We were happy to build on that. And then aorta and pulmonary artery sizing, again, information that is available there. And perhaps our crown jewel is what I referred to earlier. We referred to it as AI-CAC. Of course, now AI-CAC has a much more meaningful definition, but it's cardiac chambers volumetry. And to me, LVH, left ventricular hypertrophy, or enlarged chambers, LA, LV, they're similar to Agatston calcification discovery, that these are the end organ damage done over a period of time of exposure to risk factors. In coronary, that's calcification, response to injury and healing and all that. Here, remodeling, enlarging enlarged chambers or increased thickness. So we're very pleased that we made this original. So if I were to credit our group as one real original thing with AI, again, that also was manually referred to by Matt Budoff and folks at HNR in Hans Nixworth study in Germany at one slice level, but we developed a volumetric report on those. So I'm just going to start with the last one. The chambers, we published this significantly. We compared it with MRI, and we demonstrated that if you just take this opportunistic finding in a CAT scan based on AI and reporting chambers volume and predicting heart failure, you do just as well as if you had done it with MRI. So bottom left is MRI. These are people in Mesa who went under both CAC and MRI scan, and I want to credit the Mesa Coordinator Center and investigators who really built the stage that we're dancing on because of their hard work. So this was very eye-opener to us. And we have a bunch of examples like this. When the CAC is 0, when AI-CVD risk score in this male 54 is less than 5% 10-year risk. However, if you turn on the AI light, you will see that LV volume is massive. And in this case, in a female, the same way. And both of these had heart failure and unfortunately passed away. So this is adding on that, when we compared the enlarged chamber with diabetes, so we said diabetes is currently in national guidelines as class A, stage A of heart failure. What if we compare that with enlarged chambers? And this data shows, this is a research done by my colleague, Reza Mirjalili. He is just so meticulous that was able to unravel various aspects of this for us. This paper is hopefully will be coming out soon. The nutshell message here is if you have both chambers enlarged and diabetes, you're in a worse situation. But if you have an enlarged chamber in the top 95 percentile, even if you don't have diabetes, your risk is equal or greater, like somebody who had diabetes. And then it's also further, we advance this by saying, okay, what if we just do the ratio of LV/RV? This is also Reza's paper that is coming out. And it would show that when within an individual, you don't need to know their height and weight because chambers volume are height, weight adjusted, body surface adjusted. You just divide the ratio of LV over RV, you'll get a pretty good, solid predictive value. So here's LV/RV on the left side, predicting heart failure, CHF. Here's LA/RA, the same, and then here's LA/RV also. So all of those contributed to predictive value and has a pretty detailed review on those. And then this is echoing the same thing that I said before, but in two cohorts, pooled cohorts, MESA and Framingham. As you can see, the data is very consistent. As I said earlier, we refer to AI-CAC as a combination of calcium score and chambers, but at that time when we published, this is now 2 years old or so, and we showed that those people who had CAC 0 or CAC low risk had significantly enlarged chambers in height and a state of CHF risk. And that was shown both for heart failure and stroke and atrial fibrillation. So I covered chambers because, as I said, we did a lot of work there. But recently we found that if you go into the same scan and look at the myosteatosis, you actually find significant cardiometabolic risk estimate, where in this paper we showed that they predict the mean Hounsfield of muscle segmented by AI in the scan predicts heart failure and atrial fibrillation independently of the classic risk factors. That paper is coming out soon, and this is some more additional concept on that. Then we said, if you look at it further down, because Arthur will comment on that, that he and others also looked at myosteatosis and hepatosteatosis. So in this case, you'll see myosteatosis predicts heart failure and AFib. Hepatosteatosis predicts diabetes. Diabetes in healthy people who are not overweight and who are not hyperglycemic. So that's the finding that comes here. So in summary, myosteatosis is not good, and it's probably reflecting some level of metabolic disorder relating to insulin homeostasis in the body. We had Javier Zulueta, a distinguished pulmonologist in our team, with his help, and David and Claudia. We actually built on that and found that this myosteatosis also predicts the incidence of clinically diagnosed COPD, and we're still trying to connect the dots. Is it inflammation that everybody is a prime suspect? Is there a methodological issue here? So we're building on that. Now I'm going to pass on to my colleague, Nathan Wong, who I've been collaborating closely in the past couple of years, and we have an NIH grant application that we hope to get funded to develop what AHA did with Don Lloyd Jones and his colleagues. They really did a fantastic job of developing AI-CVD risk equations, pooled cohort equations. And now recently, last year, they introduced Prevent Score. Phenomenal job. We're just sort of mimicking what they did, but they only did clinical risk factor based, and we're combining that with imaging and risk factor. So with that, Nathan?
Well, thank you very much, Mort. And I must first say that as a cardiovascular prevention specialist, I'm very excited about the opportunities that our cardiologists, as well as specialists in diabetes and obesity medicine, may now have to better assess and manage your patient's risk with these and a broader suite of AI-CVD measures that you just discussed. I think the data in particular on myosteatosis you showed is extremely interesting and impactful. I was asked to focus on discussing some of the risk prediction stuff that we've done, and a lot of this has been focused on discussing how our AI models can better predict over existing clinical risk scoring tools for prediction of all CVD, coronary heart disease, heart failure, as well as atrial fibrillation and stroke. And so in this slide here, for example, we know that current heart failure risk prediction models really rely on traditional risk factors primarily, including the recently released Prevent Risk Score from the well-publicized American Heart Association's Cardio-Kidney Metabolic Syndrome Initiative. And while this prevent, and they actually have individual scores, not just for total CVD as well as ASCVD, but also heart failure. So this is probably going to be, the most important risk prediction score being recommended going forward, at least for the first few years. And while this score really, it incorporates body mass index and kidney function, which are very important predictors, our AI-CVD heart failure model, which incorporates chamber volumes as well as LV mass, in addition to other factors, can be shown here to provide significant improvement in the area under the curve for the prediction of incident heart failure. And from this, from our pooling of MESA and Framingham Heart Study offspring participants, we showed that a substantial portion of patients who experienced heart failure were actually classified as low risk by the Prevent Heart Failure score, but they were flagged as higher risk by the AI-CVD heart failure model. And this model really substantially improved the C statistic over the Prevent Heart Failure model. And what's shown at the bottom of this slide is a patient, an example of a 64-year-old man who developed heart failure 10 years later, and the Prevent Risk Score only predicted him to have a 3% 10-year risk of heart failure, whereas our AI-CVD model, which incorporates cardiac chamber, visceral fat volumes, as well as other things, including coronary and thoracic calcium measures, estimated to have a 20% 10-year risk. So this really kind of demonstrates how this model might really better identify people who are at risk, whereas our traditional risk scores, including the newer Prevent Risk Score, may underestimate risk. And we also showed, and I don't have a slide on this, but from our JCC paper, Journal of Cardiovascular CT paper from last year, our AI-CVD algorithms provided superior prediction of heart failure risk over BNP. Now, if we go to the next, that slide is here already. So in this slide here, here we're looking at atrial fibrillation risk prediction, and we can see how our model, which incorporates chamber sizes such as left atrial volumes, improves substantially prediction of atrial fibrillation over the charge AF score, which is currently often used, but of course, as we know, is limited to factors such as age, risk factors, as well as actually clinical history. Now, in the future, we plan to further validate our models by pulling several other major US NIH cohort studies, many that I've worked with over the last 30 years for predicting total cardiovascular disease, as well as the wider range of cardiometabolic outcomes that Dr. Nagavi showed earlier. And there'll be individual models that are tuned to specific outcomes. So this can really maximize the promise of personalized preventive cardiology. And while our models are currently being developed based on gated coronary calcium scans, this really has important implications and applicability for the approximately 20 million adults in the US that are annually getting non-gated CT scans for other reasons. So this really offers a tremendous opportunity to target these individuals who may be at higher risk of cardiovascular outcomes for earlier preventive efforts, who may not otherwise be actually detected, thus potentially saving many, many lives. And I'll finally just note that in a recent American Heart Association scientific statement on opportunistic testing of coronary calcium, just published last week, which I was involved with, notes that incorporating calcium scoring into routine risk assessment and leveraging AI to broaden access to coronary calcium data really holds a promise for more precise, personalized cardiovascular disease prevention. And the statement further emphasizes how these advances may enable clinicians to make better informed decisions, tailor interventions to address individuals' specific risk profiles, as well as improve outcomes at both the individual and population levels. So this use of AI to better identify and prevent disease earlier, I think is really going to become mainstream, hopefully, over the next few years. And the offerings of AI-CVD will really help move this forward. Thank you very much.
Thanks, Nathan. That was a good summary. So everybody knows Nathan has been in cardiovascular epidemiology and prevention for decades, past president of American Society of Preventive Cardiology, and he and his colleague developed a pooled cohort for diabetes. So that's where we started. I said, Nathan, let's do the same thing with image augmented model. And so we're building on his years of experience there. And as you can see, these are all is still being developed. So we're not yet, because we only have Mesa and Framingham so far. We're trying to get Cardia, Jackson Heart, Miami Heart, Dallas Heart, so we can just combine all and have the most comprehensive pooled cohort, the same way that the prevent and pooled cohort equation, AI-CVD, PCE has done. So with that overall background, and now that everybody is familiar with what AI-CVD can do, I'm going to just quickly walk you through how a report would be generated for practitioners, focusing on each of these components related to AI-CVD, CAC, lung, valves, aorta and pulmonary sizing, liver assessment, liver fat assessment, muscle and visceral fat assessment, pericardial fat assessment, and that the chambers that we extensively discussed. So with that, I'm going to ask Dr. Agatston, we're going back to the root, to give us a perspective